everybody. On the behalf of the Gastrointestinal Infection Society of India, I am very happy to welcome you all to the first webinar in a series of webinars which are being organized by the society. The topic for today is Helicobacter pylori, which is a very significant topic for today is Helicobacter pylori. To begin with the proceedings, I'd like to request Professor Vaishnavi. Madam is the founder of Gastrointestinal Infection Society of India, and I'll request Madam to start off the proceedings for the webinar. Over to you, ma'am.
Good evening, everybody. Welcome to this series of webinars. The Gastrointestinal Infection Society of India, abbreviated as GISI, has been academically functional since the past 15 years. Recently, the society members requested for holding regular webinars to update on different areas of gastrointestinal infections. Dr. Vishal Sharma, Associate Professor, Department of Gastroenterology, PGI, Chandigarh, took the initiative of launching this webinar series. I'm extremely pleased to introduce you to this series of webinars, which will be held under the aegis of GISI every 2 months. Today's webinar on Helicobacter pylori will be the first of the series and has been supported by InVig Healthcare, and they are the makers of Biswit. The next webinar will be on infections in inflammatory bowel disease, and I hope you will join again in large numbers. All GISI members are, as well as other participants, are requested to give their suggestions on the topics which need to be covered in this forum in future. Today's webinar will dwell upon an update on the testing and treatment of initial as well as refractory H. pylori infection. H. pylori with high tropism for the gastric epithelium, where it causes long-term colonization of the gastric mucosa, has been deemed as a carcinogen by the International Agency for Research on Cancer. And this was done in 1994. But since then, it has been increasingly accepted as the colonization of the stomach with H. pylori as the major cause of gastric carcinogenesis. Prevention via H. pylori eradication and controlling environmental factors such as diet, smoking, alcohol, etc. is an important strategy to avoid H. pylori associated gastric carcinogenesis. We have amongst us many eminent speakers like Professor Amit Dutta from CMC Vellore, Professor Usha Dutta from PGI Chandigarh, and Dr. Piyush Ranjan from Sir Gangaram Hospital, New Delhi, and they will be deliberating on this subject. Apart from them, we also have several other experts in our panel today who will give their inputs and share their experiences in this brainstorming session. And I congratulate the GISI team members as a whole, and in particular, Dr. Vishal Sharma, who has efficiently organized in this webinar and by including different esteemed faculty members. And I wish the best for its continuation in the future. I welcome the entire faculty and the registered participants who have joined us for this webinar this evening. Thank you all.
Thank you, madam, for your kind words of introduction. Now let us proceed towards the lectures, and I'd like to introduce the chairpersons for the same. Professor Rakesh Kochhar needs no introduction. He's the ex-chief of gastroenterology at the Department of Gastroenterology at Chandigarh, at PGI Chandigarh. Currently, he's the president of the Indian Society of Gastroenterology. And along with him, the other chairperson is Professor Varsha Gupta. She is the chief of microbiology at the Government Medical College and Hospital, Sector 32 in Chandigarh. Over to you, chairpersons.
Thank you, Dr. Vishal. And I must compliment Dr. Chetna Vaishnavi for initiating this webinar series. And I'm sure that this will be a big success, particularly because it is focused upon GI infections. So today the whole issue is about H. pylori, and we have the first talk on testing for H. pylori, when and how. Professor Amit Dutta, one of the brighter stars, younger brighter stars of gastroenterology in the country, is going to deliver this talk. He's at CMC Vellore, and I'll request Dr. Amit Datta to please talk on testing for H. pylori, when and how. Dr. Amit.
Yes, thank you. Thank you, sir, for your kind words of introduction. Is my slide visible, sir?
Yes, yes.
So first of all, I would like to thank the Gastrointestinal Infectious Society for inviting me, especially Dr. Vishal and Dr. Chetna for inviting me for this presentation. So I'll be speaking on the tests for Helicobacter pylori. I mean, how to test and when should we test for this infection. So we know that there are multiple tests are available for detecting H. pylori infection. This includes both invasive and non-invasive tests. Invasive means where you need an endoscopy, non-invasive where you do not need an endoscopy. So what are these tests and which one should we choose for our patient? And we also know that H. pylori infection is common in our country. You know, more than 50% of our population is infected with H. pylori. So the infection is so common in our country, and everybody does not require to be tested or treated for this infection. So who are the patients who need to be tested for H. pylori? So I'll be discussing this as well in a few slides. So moving on to the methods of testing, that is how to test. So there are multiple tests available and they make use of different property of the bacteria for the test. So for example, there are tests which detect the entire organism as in the histopathology. Then there are tests which make use of the urease producing property like the rapid urease test or the urea breath test. Then antigen detection tests for detecting bacterial antigens are there. Then there are tests for detecting the antibody of the bacteria in the serum. We also have molecular tests which look at the bacterial genes, the DNA. So there are multiple tests available. And these tests, again, as I said, make use of different property of the bacteria. And these tests are broadly divided into two main groups. You have the non-invasive test and you have the invasive test. So the main difference is that in non-invasive test, you do not require an upper GI endoscopy, whereas in invasive test, you require endoscopy with gastric mucosal biopsy. So among the non-invasive tests, we have the urea breath test, we have the stool test and stool antigen for H. pylori, and there is serology, of which the urea breath test and the H. pylori antigen are the ones which are commonly done. Among the invasive tests, again, we have a test making use of the urease producing property, which is the rapid urease test, and the histopathology. These are the ones which are done commonly in clinical practice. Tests like culture and PCR are expensive and not easily available, so they're not done routinely in clinical practice. Okay. So first, I'll be discussing about the non-invasive tests, then about the invasive tests. So among the non-invasive tests, the urea breath test is something which is probably the most commonly done. So in this test, what happens is that patient takes urea, which is labeled with carbon isotope. So the carbon has either the 13C labeling or a 14C labeling. 14C is radioactive, 13C is not radioactive. So this is taken orally by the patient. And if the patient has H. pylori infection, then the urease, which is produced by the bacteria in the stomach, actually breaks down the urea into carbon dioxide and ammonia. So this carbon dioxide then which is released is exhaled in the breath, and this is then detected. So simple principle. If there is H. pylori, the urease activity will break down the urea and then the carbon dioxide will get released, which is then detected. So the 13C is the one which is preferred because it does not deal with the non-radioactive material. The results for this urea breath test, they are available rapidly. In 15 to 30 minutes, you get the results of this test. And they are quite sensitive. They're very sensitive and specific. So the performance is very good. The main thing to remember for this test, as well as some of the other tests, is that the patient has to be off PPI. So they should stop a proton pump inhibitor for at least 2 weeks before testing. And if they are on antibiotic or bismuth, then they should be stopped for at least, they should not have been on these compounds for at least 4 weeks. Also, in the presence of active GI bleeding, the sensitivity gets reduced. Then the next commonly done non-invasive test is the stool antigen test. This, as the name suggests, it detects H. pylori antigen in the stool. So the testing can be done on a fresh stool sample. If the testing is delayed, then we can freeze the sample and do the test later. Earlier, they were polyclonal antibody, but they are not very accurate. So currently, the tests which are done are mostly the monoclonal antibody and based on the principle of enzyme immunoassay. Now, one thing to remember for this antigen test is that there are differences in the strain of H. pylori in different populations. So when you are doing a test, you should validate that what the antigen you are checking is prevalent in the population that you are testing. There are also rapid point of care tests available for this antigen where you can place the sample and you can get the results rapidly. So stool antigen also has a very good sensitivity and specificity. And this test is mainly useful in pediatric population where it may not be practical for them to comply with the instructions of the urea breath test. No? The exhaling out and all, they may not be compliant to do that. So it's useful in that situation as well as for testing successful eradication. So here also you have to remember that the patient has to be off PPI for 2 weeks and he should have not taken any antibiotic or bismuth for 4 weeks. One good thing is that GI bleed actually affects the performance of many of the tests, but for the stool antigen, the effect is lesser than it is for a breath test. So these are the two commonly done non-invasive tests. You have the urea breath test and the antigen in stool. Now the antibody, again, the antibody test is one which is not done commonly in clinical practice because antibody is not very good in differentiating a current infection from a past infection. So because it cannot differentiate current from a past with a lot of reliability, so the recommendations are that you don't use it for a clinical purpose. It is mainly used in epidemiological setting where you want to know the rate of infection. So that's for the urea breath test and the stool antigen are the two commonly done non-invasive tests. Next, we move on to the invasive tests. And among the invasive tests, again, the two most commonly done tests are the rapid urease test and the histopathology. So rapid urease test, the principle is similar to the urea breath test. In rapid urease test, the patient is having endoscopy and during endoscopy, you take a sample from the stomach. And please remember that sample from both antrum as well as body, because if you take sample only from one side, the infection is actually patchy and therefore you may miss infection in some patients. So therefore, you should take biopsy from at least two sides, one from antrum, one from body. Then there are multiple kits available for this rapid urease testing, but what they all have in common is that they have urea and they have a pH indicator. So again, like in breath test, if the biopsy specimen contains H. pylori, the urease activity of the bacteria is going to break down the urea into ammonium and carbon dioxide. This leads to a change in the pH, which is detected by a pH indicator. So in a positive test, there is a change in color, and that's how we detect a positive test. And there are multiple commercial kits available. Also, there are in-house made kits available, which are cheaper to make. So for example, in our institute in CMC Vellore, we have our own in-house kits, which we have been using for the past few years, and they are quite good. And again, the results can be read from 1 to 24 hours, depending on the instructions from the kit manufacturer. This test has also been shown to have a very good sensitivity and specificity. And like for the other test, the patient should be off PPI for 2 weeks, and they should have not taken any antibiotic or bismuth compound for 4 weeks. Also, in the presence of active GI bleeding, there is reduced sensitivity for this testing. And just to highlight again that when we do a rapid urea, because this is one of the most commonly done invasive tests when you're doing endoscopy, the commonly done test for H. pylori is a rapid urease test. Just to highlight the point again that when you do this test, please take biopsy from both body, antrum as well as body. We had done a prospective study and we presented the data last year in DDW that we had about 168 patients with peptic ulcer and 104 of them were positive for H. pylori and RUT. Of this 104, 10 were only picked up on a gastric body RUT. So if we didn't do this from the body, we would have missed these cases. And we know that if we don't detect infection, if we don't treat, there's a high risk of recurrence of ulcer. The next important invasive test is histopathology. And as for the rapid urease test, even for histopathology, biopsy from multiple sites is recommended to improve the yield. The bacteria can be detected on the routine H&E staining, but there are also special stains like GIMSA, Wardenstari, or immunohistochemistry. The important thing to remember in pathology is that you have to examine multiple fields before you say the infection is not there. So for example, our pathologist tells us that they look at 100 fields before they say there is no infection. So it depends on the pathologist's experience, the time they spent in the test. The benefit of histopathology is that it also identifies any underlying pathology like atrophy, metaplasia, etc. But again, these tests are expensive. It takes some time for the result to come. And these can also be affected by use of PPI, antibiotic, etc. The one major benefit of histopathology is that it's very specific. If you see, then more than 98% certain you know that this is H. pylori infection. So this again shows picture of bacteria on H&E, Giemsa, Wardenstari, and immunohistochemistry, they are quite easy to detect. They require special media and special conditions for growth. So therefore, they are not used for routine diagnosis. Their main utility is in drug sensitivity testing. So patients who have previously failed drug therapy and you want to check for any sensitivity, that's where it is helpful. And it's again not routinely available. Similarly, for PCR can be done on a gastric biopsy specimen or even on a stool specimen. It's quite a sensitive test, and the benefit of PCR again is that you can also, apart from bacterial genes, you can also detect genes for antibiotic resistance, but they are again expensive and they're not routinely available. And just one quick word about this newer advanced endoscopic imaging techniques. So nowadays we have this advanced imaging where you can look at the mucosa in a lot of details. So now there are features which are suggestive of H. pylori infections. For example, on a narrowband imaging, if you look at the stomach, normally you see these collecting venules, which are these dark brown structures. But in H. pylori, this disappears, as you see in this picture. And this is about 80 to 85% sensitive to pick up an infection. Similarly, you can see features of infection on a confocal laser endomicroscopy. But just to caution you that these are not replacements for your usual testing because they are not direct testing. But just for interest, I am putting this. But this is not a substitute and these are not recommended for detecting infection. So now that I have discussed the commonly done invasive and non-invasive tests, this table shows the comparison of performance of these four tests. So the urea breath test and the stool antigen, which are the non-invasive, and rapid urea and histology, which are the invasive tests. And as you can see, the performance-wise, they are sort of not too much of difference between them. So then how do we decide that which test should we be doing? So the main question to ask is, does the patient require an upper GI endoscopy for a clinical indication? So upper GI endoscopy should not be done only for testing. If you're doing an upper GI endoscopy for a clinical indication, then in that patient, it's easier to do a test like a rapid urease or you can do a histopathology. But if you do not require upper GI endoscopy, then in those patients, you should go for non-invasive tests like a urea breath test or a stool antigen. Again, there are questions about whether we should do one test or two tests. But if you look at the guidelines like the Maastricht consensus or our own ISG guidelines, I think one test is okay for clinical purpose. But for research settings, they say you should have at least two positive tests to say that there is infection. So for clinical purpose, I think one test probably is sufficient. So recently, the ISG task force on H. pylori, they published their Bhubaneswar consensus guidelines on how to manage H. pylori. And these are the main statements with regard to the diagnosis. So what they say is that non-invasive tests are appropriate if endoscopy is not indicated. Also, if endoscopy is indicated, then rapid urease test is the first line diagnostic test. Additionally, histopathology from antrum and body. And for culture, only if there is failure of second line therapy should we embark on culture and antibiotic sensitivity. And they are very clear in stating that serological tests have no role in management of H. pylori. Now, just a couple of slides before I conclude on so as I said, infection is so common in our country. So whom should we test for H. pylori? So there are some well-established indications for this, which includes patients who have gastric ulcer, duodenal ulcer, patients with early gastric cancer, those who have a family history of gastric cancer, patients with gastric mort lymphoma. Another group is patients who are going to be on long-term NSAID aspirin. This probably is one of those indications where I think because these guys don't come too much to gastro, they are usually seen in cardiology practice, the H. pylori testing may not be happening. But this is one group where there is again a recommendation that if you eradicate H. pylori, the risk of lesser. So those who are going to be or who are already on long-term NSAID and aspirin, that's one group where we should check for H. pylori. And finally, dyspepsia. Now, dyspepsia, we know, is a very common condition. There are multiple factors which contribute to dyspeptic symptoms. And one of the factors is H. pylori. So in the Western country, they say that if you should do a test and treat strategy where you check for H. pylori and eradicate if it is present in patients who are having dyspepsia. However, in India, because the infection is so common right now, we are not sure whether this should be, and our ISG task force on H. pylori said that this should not be the first approach for dyspepsia. But this is one group where you can test for H. pylori for testing. Then there are some other indications, but in these indications, the association is not very strong, and H. pylori is not the main causative factor for these conditions. But here again, there is a recommendation to test and treat, which includes unexplained iron deficiency anemia, idiopathic thrombocytopenic purpura, and vitamin B12 deficiency. So to conclude, so as I said, multiple tests are available for detecting H. pylori infection. The test we'll do depends on the clinical setting, the cost, and the availability of what we have. If you are doing an endoscopy for clinical evaluation of symptoms, then you can go for invasive tests like a rapid urease test or the histopathology. Otherwise, a non-invasive test like an H. pylori is common, but we should only treat when there is an indication for therapy. Another thing to remember is that there is the resistance to bacteria is there, and therefore, if you're treating somebody, we should also ensure that we also check for successful eradication. So with that, I come to the end of my presentation. Thank you.
Thank you, Dr. Amit, for a very clear and simple disposition of the subject. It sets the ball rolling for the next talks. So I'll hand over the mic to my co-chair, Dr. Varsha Gupta.